But today's going to be a little different. So today we're going to go through cases together. So I'll give you a few minutes to read over cases as we do them. But in general, we're going to go through them together and move through the process as a group instead of on a more individual level. And again, that's because we rarely see these conditions. When we see these conditions, it's something that I wouldn't want you to memorize. It's something that I would want you to look up. So what we're going to do, though, is highlight the must-knows, the red flags. If you're in practice anywhere, something comes across, you're checking an order or you're entering an order or you have a patient that comes in the clinic or whatever it might be, I want those red flags to go up, okay? So what our goal for today is going to be to highlight our red flags when it comes to adrenal and pituitary conditions. The other piece of today's lecture that I think is really important is more so that you understand the background of these conditions and why do we have issues in terms of adrenal issues and pituitary issues. So that piece of information is in your pre-lecture, which hopefully you watched before you came to class today. To help you wade through that, I put a chart up on Friday. So if you didn't get to it over the weekend, it's fine. We'll talk about some of it in class today, but I encourage you to make sure that you go back and listen to the pre-lecture, fill out the little chart that's on the ELC, and kind of work through that to get a better understanding of sort of what's going on with the condition. And then once you kind of understand what's going on, then you can start to think through what therapies.
She just kind of. Is the mic dead?
Dr. Misher, we can't hear you if you're speaking.
Why is there always a problem when someone's speaking from Savannah?
Wait, so why did y'all think that it was a pituitary?
Dr. Misher, Athens campus cannot hear you if you're presenting.
Neither can Augusta.
Yes.
Augusta?
Yes, ma'am.
Yes, we can.
All right, okay, we're back. That's good. I didn't hear the last 3 minutes of what I said. We're going to go back and do it again. All right, so what I was saying, since none of y'all could hear me, was that, recap, is that I taught this lecture last year, and I taught it with lots of granularity. So we went into pharmacotherapy, pathophysiology, the monitoring of every single drug, and it was very overwhelming and a lot of information. So this year, instead, and then what I figured out is most of you are probably hardly ever going to see these conditions. And so what we really want to do is highlight just the red flags today instead of going to a very granular level, okay? But I kept my slides, especially the cases, on the granular level, so that way when you go back and look at this information in the future, you'll be able to have kind of a recollection and do some more in-depth investigating. So what I want us to pick out, the highlight there, what I want us to pick out is the red flags, okay? So we're going to talk about the red flags of all these therapies, who do we choose the medications for, and why. All right? The other thing that I mentioned was that I posted a pre-lecture, and I anticipate that all of you have already listened to the pre-lecture. And then on Friday, I put up a chart for you to be able to kind of think through each disease state, what's going on with that disease state, and then what is the pharmacotherapy to treat that disease state. All right? So it doesn't matter if you do the chart, but as you study for assessment purposes, it may be helpful as you kind of think through all the disease states. Okay? So, today we're going to talk about pharmacotherapy. We're going to talk about all the sort of different conditions in terms of adrenal and pituitary disorders. The other thing that I want us to touch on, because it fits really nicely in this sort of category, is the HPA axis and what happens when we suppress the HPA axis. And then we'll talk a little bit, because it doesn't really fit sort of anywhere else. We're going to talk about gender dysmorphia, what that is, and why, how do we treat those patients. All right? Y'all can still hear me at the other campuses?
Yes, ma'am.
Let's take that as a yes. And when I move forward, it's a lot. I know.
I think I'm
All right.
getting puffy.
Give me a quick ask if you can hear me. Alvin, Dustin, somebody give me a heads up. Okay,
Julie,
perfect. Okay, we're good to go.
Athens.
Perfect. Good. Okay, so we're going to start with Cushing's disease. So tell me, anybody. And I'm not in the mood to call in groups today, so as long as y'all are interactive, I'm not going to do the group calling thing. We're just going to do this in the group. All right, so Cushing's. Tell me, what is the situation in Cushing's? Which hormone is affected and how in Cushing's?
Too much cortisol.
Increased cortisol. Very good. So we're talking about the adrenal gland. We have our 3 different hormones that we typically think of for hormonal release. We have cortisol, we have aldosterone, and we have our androgen. Okay? So what we're going to start with is increased cortisol. Right? Typically, we don't see a lot of these patients, Cushing's patients, because a lot of times what we're doing is just treating around when they're going to have some kind of surgery to help fix the situation that's going on. So most of the time it's a tumor or some sort of hyperplasia. So most of the time what we'll do is surgery, just get it out of the way and kind of be done with it. But we'll do some pre-op, post-op sort of help in the meantime. All right? Why are we worried about high cortisol levels? What does high cortisol result with? What's our goal of treatment here? Why do we need cortisol? Somebody in Athens, tell me, what does cortisol do in our body? Why do we have cortisol?
It's a stress hormone.
Very good. Stress, right? So when we get stressed, our body needs to respond to this stress, and so we produce cortisol. So anytime we go through a stressful situation, that's what happens. So this morning, most of us, some of us, woke up this morning, right? So it's cortisol that woke us up this morning. Our body needs a little bit of stress to get up in the morning, so we produce cortisol. All right? So we need at least some cortisol in the body, but we don't want to have too much. When we go to the opposite end of stress, what disease states do you typically think that leads to? We get stressed out, we do what? Yeah, very good. Thank you. Yeah, cardiovascular disease, right? So what comes with cardiovascular disease is obesity, right? We have diabetes, high cholesterol, high blood pressure. So all of that we can think of as sort of that whole process together of cardiovascular disease and really the general effect of increased cortisol. So the goal of therapy is really going to be, in this case, for 1, to fix the adrenal gland, and for 2, to stop those detrimental effects of cardiovascular disease. So we have a bunch of different categories of drugs that treat this, and basically what all of these do is decrease cortisol levels. So we're going to keep it basic, like I said this year, and what you should know about all these different classes is they decrease your cortisol. All right, so let's kind of go through each drug individually, and what I mentioned earlier was we're going to hit the highlights and hit we use this in and how do we use it? So the first drug that we're going to use is, Meteropone. Alright, and this is pretty much used in our sort of compassionate. We typically don't use it as monotherapy, but what's really nice is it has a really quick onset. So we can get patients started, we can get their cortisol levels down, and kind of move on to what's next. But usually this is our starter. We don't use this in pregnancy. So, alright. So if I was going to highlight a group of patients that we don't use it for, we're going to say don't use in pregnancy. Alright? Okay. Next, ketoconazole. What do we typically use ketoconazole for?
Fungal.
Yep, antifungal, right? So it seems weird to use it for outside antifungal, but you know, for a lot of different medications, we use them off-label. This is kind of an off-label use, or less, I guess I wouldn't say off-label, but less used. Ketoconazole, one of our biggest side effects of ketoconazole is gynecomastia. So gynecomastia, which patient population would you not use this in?
Males.
Yeah, right? So it's effective, it works well, it's one of our go-tos. Use it in women, use it in all kinds of women. That said, that we don't use a lot of these therapies in pregnant women, but ketoconazole we can use in pregnant women, but we would not try to use this in men if we didn't have to. Okay? Next, we have accommodate. What do we use that for? The inpatient people.
RSI.
IV sedation.
Yes, sedation, right? So again, not a common use to use it for Cushing, but we use it especially in emergent situations. Right?
Dr. Misher,
Yeah, go for it.
could you just clarify, so you have hirsutism and acne listed next to meteropone. Are you saying that those are like adverse effects of the drug, or that it would be an appropriate drug for patients that are dealing with that?
Side effects of the drug. So hirsutism and acne, because it has androgen properties, the side effect. Also, that's also why you would not want to use it in pregnant women, is because that androgen effect.
Okay, thank you.
Yep, good question. All right, so we got some basics, right? We have the meteropone to kind of do a quick onset, get the disease under control very quickly, because that's a quick onset. But we have our patients we don't use it in, and we do not use it in pregnant women. We don't use it in women that want acne. Although acne is better than having really high cortisol levels. So you can use it for women, not pregnant women. But you do want to limit women because of that. Good point. Ketoconazole is more long-term, especially if you can't have patients, you have patients who cannot have surgery. It's typically longer acting, but we don't use it in our men. Avoid in men as much as possible. Again, getting things under control is better than not control. So if you don't have any other options, then we would still use it, but we try to avoid it in men. And then we have accommodate if used in emergency situations. All right, moving on. We have mitotane. Mitotane also has a slow onset.
Dr. Misher, I'm sorry to interrupt. I have a quick question.
Go for it.
What would be an example of an emergent situation?
Emergency situation would be a fast-growing tumor. So if you had a really fast-growing tumor that you needed really quick, or if the patient's about to go into surgery and you want to get some control of the disease state before they go to surgery, we want to do it quickly. Although when we talk about conditions, we don't typically for Cushing because of the effects are more long-term, they're more cardiovascular that we're worried about. The emergent situation is far less, but you can have situations where the adrenal gland is just pumping out that cortisol, and that can be dangerous.
Okay, thank you.
That make sense? It all depends on sort of the situation, patient to patient. You can have some really fast growing, pretty soon sugars. All right. So Mytase has a slower onset, kind of like what we said for ketoconazole. So it'll be a longer term therapy. It's not for our emergent situation. And the other thing I want to highlight about Mytase is to avoid pregnancy as well. All right. Basic stuff. Basic stuff. Okay. We're going to highlight patients to avoid. So again, I have lots of details on all these slides, but we're going to keep them basic. Basically, I want you to know the name of the drug, and I want you to know what patient population uses it. All right. Next. Paracetamol. Have y'all seen this before? It's just like I've never seen this drug before. That's what I thought. So we're gonna again keep it basic because y'all don't see these a lot. These are not common. Again, a paracetamol is something you can use for don't want it in combination with ketoconazole or other type therapy. Other note about paracetamol, your red flag in paracetamol is to check patients' blood sugars because their blood sugars can be elevated. That kind of third point about monitor blood glucose is important. I know for students it's super stressful to not go super in depth about every drug. That's what you guys are super used to, especially with pharmacotherapy. But I know you guys aren't going to see these conditions a lot, so I don't want you guys to get bogged down in all the details that are on these slides. So I want you to be able to pick out drug therapies. I want you to pick out the red flags. Tell me what patients are they good in, what patients are they not. All right? If you really saw a patient with Cushing's, what I want you to do is look it up. I know you never hear that in pharmacotherapy, and that's very scary as a student. But the real answer for this is I want you to look it up. Okay? But I don't want a student to bog down in detail. So I'm going back to the slides on purpose because I don't want you to get stressed about memorizing all the details on all the slides. I want them to be there for your information. Okay? I want us to get a basic understanding of the disease state. I want us to hit the highlights so that way when you see a medication come up, you'll have that one red flag or the red flag, maybe about that drug therapy, and be able to be like, whoa, 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 whoa. This isn't something I see all the time, or this is a weird use of this drug, kind of like you said for ketoconazole, right? Maybe they're on it long term and that feels really weird. That's what I want you to pick out. Or you see ketoconazole in a male, and you're like, wait a second, that feels really weird. Long term in a male isn't this right. Does that make sense?
Would you want this drug in your diabetic patients or just monitor them more closely?
Typically, that's a really good question. Typically, I would monitor more closely. If you want to control Cushing, if you don't get the Cushing's under control, you're not going to get the diabetes under control. You need to monitor more closely, and you might step up your therapy very quickly. The anti-diabetic medication for the patient. All right.
Monitor.
Next drug. Pharmacotherapy. Patients do not use this in pregnant patients. Have y'all seen this drug before? Where did you see this drug before?
It's abortion.
What have you used it for?
Abortion.
For abortion.
Yeah, or to induce labor, right? So, because it induces labor, we don't want to use it in pregnancy in a patient that we want to keep the pregnancy viable. Okay? But it's effective when it comes to controlling cortisol. All right. That was like a 5-second overview on purpose.
That was
Don't
not
use the
5
granular
seconds.
level. I see scared faces in Savannah, which means there are scared faces now. Albany, Augusta, and Athens. So I promise that is not scary, okay? So what we're gonna do is we're gonna pull up in the cases. I want you to go to the ELC,
Oh no, I can't hear you what you're saying.
pull down your case. We're gonna go through cases together today, okay? Remember, when I did the case, when I wrote the cases, I purposely wrote them with lots of granularity. I purposely today did not want you to have lots of granularity. We're going to go through it together, so that way you guys can hit those highlights, hit the red spots. Okay? All right. So what I am going to do though, is what I don't like to do is to have them let think individually gather their thoughts. I want you all to be able to do that. So I'm going to give you 5 minutes or so to read the case and start to get your thoughts together on what's going on. The first case, case number 1, is a phishing case. I'll give you 5 minutes to read it, and then we're going to come together and we're going to come up with answers together. All right? So take 5 minutes.
BCADM.
What's
I know CDE and CDE, but I don't know what ADM is.
diabetes education?
That's what CDE is. Certified diabetes. Certified. That's ambulatory care judge.
Aaron, what are the normal ACTH levels?
I don't know, but she has a tumor on her pituitary, so I'm assuming it's high. She didn't give us levels in the pre-lecture.
Yeah, she didn't give us anything.
I'll have to look at those.
Can we do the
10 to 50 picograms per mil.
Oh, and hers is.
Yeah, it's like 10
Oh,
to
wait.
50 micrograms per liter, probably.
What is
Normal ACTH.
10 to 50?
10 to 50 is what Google.
Board certified advanced clinical diabetes. We could do that. The entire because that was monotherapy.
Just like compassionate use.
Yeah, what does that mean?
Compassionate use?
What's that
Like,
mean?
is that what, like when people are dying, you just do it to make them comfortable?
That's not what she was implying when she talked about it.
Why does she like cut in and out when she talks? Because I feel like
Well, she was saying if it's, you don't use it as monotherapy because it's like not good that way, but like probably if someone's
said
dying.
nitrogen.
Hmm?
I said nitrogen.
GI side effects may bother her. GERD.
Aaron, do you shave your toes?
That would be very
How come people make fun of you
What?
when you don't even shave your toes?
All right, y'all can you happen?
Oh my god. So they have like, oh, I have like no.
We do.
My hair's super thin.
I have very hairy toes.
And that's
I did that.
and that's
Mr. Arnold will have all kinds of like adapters.
We can hear you.
I put it on
not drowning?
my drive.
Underwater? Good? Okay. All right. So we have a patient in our case that has Cushing's. What are some of our hallmarks of Cushing's in terms of clinical presentation?
Is that green? I like that. Green. Why'd they pick yellow? Looks like John Deere.
Brown, red face,
Yep, around red face.
that around the abdomen area
Good.
and on top.
Good. So we have round red face.
We can't hear anything that they're saying.
Confidence, Casey. Got it.
Fat in the abdomen area, fat pads on the clavicles, red round face.
Did I get that?
Yes.
Maybe your mics aren't working. Okay, I'm just gonna say them then. Okay, so Casey thankfully informed us. Patient has round red face. They have fat around the abdomen, and they have little fat pads on the clavicles. Okay? So key of Cushing's is, for one, abdominal obesity, which is good, and fat on the clavicles, which is good. Because fat distributes kind of weird in Cushing's. So that's kind of one of our things, like, the person's like gaining weight, but they're gaining weight kind of weird. That's kind of one of our signs, like, something's up, something's weird. And that round red face, again, something's not quite right. Okay? Good. So, by presentation, just by looking at them, you can see that they have some of the telltale signs of Cushing's. So, weird fat distribution, round red face for this particular patient. If we look at blood pressure, is this patient's blood pressure elevated? Yep, hypertension, right? Is their blood sugar elevated? Yeah, 155 is not really a normal blood sugar, right? So then we start to see kind of what we talked about before, is these beginnings of cardiovascular disease or progression of cardiovascular disease as well. All right? Okay. So some of our clinical signs, our lab values are starting to indicate her cholesterol is off, likely, her triglycerides are probably off. If we were to look at a lipid panel, which I don't remember if I gave you or not, but I don't think I did. but labs are off, typically kind of all across the board, and we still think of those under the cardiovascular situations. Okay? So what we want to do is get her cortisol under control, so we have to come up with drug therapy options. When you look at this patient, what are some big things that you think of in terms of choosing a treatment for Cushing? Is she a she or is she a male? Is she, right? So it's a female patient. I had to go with it because I couldn't remember if it was male or female. So she's a she, she's a female, right? Okay. So female patient. So when we think of a female patient, let's start with, what's your first question you would ask yourself based on sort of the big highlights that we talked about before? Female patient. Say it again, that was really good. It just didn't come across clear on the mic.
Sorry, is she pregnant?
Is she pregnant? Very good question. Is our patient pregnant in this case? No, she's not currently pregnant, but is she of childbearing age? Yeah, kind of. Right, maybe 42. Technically, she can still get pregnant.
Get her tube tied.
So we do have to be a little careful, but chances are at 42, she's maybe not heading in that direction would be my guess. Although that's certainly a conversation we would have with her. She has kids, so maybe she does, maybe she doesn't want more. So good first question. Good. She's a she, and she's not a man. So, which is that also? And we're going to pick treatments that are good for females, not for men. Okay? So as we talked about our big highlights for this section, figuring out the gender of your patient and figuring out if you have a female, what's the pregnancy status. Okay? Perfect. One more aspect that I typically think of and you highlighted for drug therapy was acuity, correct? So does it seem like she's in an emergent situation? Alvin, what do you think? Do you think she's in an emergent situation?
I don't think so.
Nah, doesn't really seem like it, right? So then that means we want some of our longer term therapies. So let's start with the slide that I have up now. On this slide, what medications are we going to eliminate based on those three factors? It's a female, she's probably not trying to get pregnant, although we're going to have that conversation, and not an emergent situation.
Accommodate.
Yeah, so we can get rid of accommodate, right? It's the emergent situation. Good. What else can we get rid of on this slide? She's a female, right? She doesn't want acne. Probably doesn't want hair growth everywhere. What else can we on this slide?
Two men?
Augusto, what will we eliminate from this slide?
Retire phone.
Tire phone. Right. Good. I believe the conazole is an option for this patient. Okay? So ketoconazole is a good option for this patient. Okay? Good. Next slide. Mitotane. Is she a candidate for mitotane? Athens, what do you think?
Yeah.
Yeah, she'd be a good candidate as long as she's not trying to get pregnant, right? Slower onset, so we're going to use it for a while probably. Not an emergent situation. Female patient, good to go. She was a man who we use this therapy. Yeah, right? Okay, good. Paraceratype.
Oh, she's talking.
Paraceratype. Get some head shakes, Banner. I'm going to say yes. Where would be our hesitation?
She already has hyperglycemia.
He already has hyperglycemia. Perfect. So we'd be a little bit cautious because she already has hyperglycemia. So we'd at least do, to get to Casey's point earlier, we would do lots of monitoring of her blood glucose to make sure that her sugar stays under control. Okay? Good. Keep pressed down. Hand it up for this. She's not trying to get pregnant, right? So another good option. Okay? As you can see, we have lots of different options. When we think about side effect profiles, fluconazole is probably our best option. But I don't expect you on that regular level. Give me the basics, guys. Okay? Are we comfortable with kind of what we went over and figuring out yes, no in terms of therapies? Big overview? Okay. My next question that I posed to you was my granular question. Don't want you to know drug dosing for this particular drugs. So avoid the part that says drug dose and frequency. I just want you to know drug, yes or no. And then clinical monitoring kind of makes sense. You're going to monitor for her cortisol levels, correct? And we talked about a little bit of monitoring and maybe in paracetamol monitoring her blood glucose. Okay? And then monitoring the patient's lifestyle is also important. Making sure we're really understanding, is she trying to get pregnant, yes or no? And then monitoring to make sure it's not an emergent situation. She's not having emergent adverse effects. And we're going to keep it that. All right. So educational points about those drugs is everything we just covered, right? Primarily thinking about which drugs can we use in pregnancy, which drugs can we not use in pregnancy, and if she is of childbearing age, kind of, sort of, making sure we're doing that education to make sure she's using some sort of protection or contraception or something to make sure she's not going to get pregnant, even if it's not intended. All right?
So how would you define whether the patient needs a long-term or a short-term option?
Yeah. How do you pick long-term? It depends on what's going on with that tumor or what's going on with the adrenal gland in general. So if it's a patient who is about to, like we talked about earlier, about to go under surgery, then maybe you'd pick a more quick onset, short-term med. Or if it's a situation where surgery is not possible at this time or possibly delayed for some reason, or they're post-op and we're just kind of trying to handle things in the interim, then we might pick a longer term medication. That makes sense. So it's very patient specific. Is that helpful?
So it would say in the case whether or not they need surgery.
Yes. If it's an emergent situation, for assessment purposes, we're keeping this granular, right? For assessment purposes, I would say if this is an emergent situation, patient is in the ED, okay? But otherwise assume that it's long-term care. I would give you like some major words that say emergency.
No, and they.
So Lynn's question is, when would you pick your phone over a time date? It depends on the acuity. So we'll go back to that slide. And this is granularity. Let me clarify. Granularity, I don't expect you to know. So a time date is emergent situation, like I'm in the ED and cortisol levels are insane and it's super scary. We'll put it that way. Meterapone is you have surgery in the next couple weeks. You want to get things under control and let's kind of calm things down before you go into surgery. So a time date is, it would say that. I would put that in the case. I am not going to be that specific in terms of is this super emergency or is this kind of emergency? Too much here today. Okay. I would not expect that you go on rotation and know that. That's not something I would anticipate that if you were in the ED and you had a patient, Cushing's patient come in as a preceptor, I would not. Okay? People are managed by endocrinologists, they're managed by specialists. All right, we're gonna move on. Any other questions before we move on though? Before we move on to hyperaldosteronism?
I'm wondering, how did you know that that patient wasn't pregnant?
How did we know the patient wasn't pregnant? Very good, we didn't. So we should have done a pregnancy test, right? Did I give you a negative pregnancy test? I probably didn't in the case. Very good, I didn't, right? She could have been. We would have had a conversation with her. Or you could run a pregnancy test. One, two. Is that helpful?
Yes, thank you.
Okay. Yes, pregnancy test would vet, have a conversation with the patient is also important. But based on her age at 42, it would be one of those things that is more rare. Not that that doesn't happen. But I jumped to conclusions based on her age. Inappropriate. Thanks, okay? Any other questions about Cushing before we move on to hyperaldosteronism? Alright. So then, in that case, we're going to move to hyperaldosterone. So, what hormone are we talking about with hyperaldosterone? Aldosterone. Said aldosterone. Are we talking about high aldosterone or low aldosterone? High aldosterone. Good. So, when we think of aldosterone, what disease state do we think of aldosterone being an issue?
Blood pressure.
Say it, just like that.
They've already covered in pharmacotherapy. We have lots of drugs to treat.
Oh my god.
What is aldosterone control?
Hypertension.
Hypertension. Very good. So aldosterone is one of our hormones that regulates our blood pressure. Okay? And in general, a mineral corticoid, right? So think of minerals or our electrolytes and our water fluid balance, which y'all just had some lectures on, okay? So we're trying to manage the fluid electrolyte balance in the body with aldosterone. So hypertension. Our goal of therapy is to control the patient's hypertension. Again, we can, if we have an issue with the adrenal gland, then we can do some sort of resection, or we can do pharmacotherapy, depending on what's going on with the patient. Again, don't need a granular level. I don't need you to know what type of situation is going on with the adrenal. I just need you to know that they have hyperaldosteronism. Okay? All right. So when we treat hyperaldosterone, what we're really treating is the patient's blood pressure. So when we think of agents to use for hyperaldosterone, we're going to go to our hypertensive agents. So here's a little bit more specifics that we're going to have to think through is the mechanism of action of each one of these drug classes. Okay? So if aldosterone is our problem, then we are going to pick antagonists of aldosterone as our primary thing, right? That would make sense. We have a drug class that does that. So we're going to pick our aldosterone antagonists. Okay? So spironolactone or clarinone, right? But most of the time we'll go with spironolactone or clarinone. Here's a red flag I need you guys to know about spironolactone. Is that for hyperaldosteronism, maximum dose of spironolactone is 400 milligrams. What's a typical dose of spironolactone that you would see in the clinic? Somebody in Albany, tell me what's a normal typical dose of spironolactone you would commonly see?
25.
25, okay, good. A little bit higher. Athens, what do you think? What else could you see?
25 to 100.
Okay, maybe 100. You can push it. If we really want to push it, what does Lexicon say? Probably like 200? I got a shake of head, yes. Lexi said something like 200, and that's like pushing it for my hypertension patients. Okay? But for these patients, because we specifically know that aldosterone is the issue, and that's what we want to antagonize, we'll go to higher doses. So 400 milligrams for this patient population. Okay. If we're going to go to really high doses of spironolactone, what's we need to monitor?
Potassium.
Potassium. Yeah. Good. What else?
Gynecomastia.
Gynecomastia, very good. That's a really good one. One more.
Blood pressure.
On labs. Or what's affecting their fluid status, right? So if we affect the fluid, what organ are we affecting? Stage 3.
Wow.
Get your mic.
Kidney function.
Kidney function, right? So what lab? What lab?
Serum creatinine.
Serum creatinine.
Serum creatinine. Very good. It's like I'm trying to try. Okay, good. Y'all hit it perfectly. Perfect. The spironolactone, 400 milligrams. What we're going to monitor is potassium, serum creatinine, gynecomastia. I love that you made the comment of gynecomastia because how do we pick between spironolactone and eplerenone?
Their gender.
Is gynecomastia, right? So if I had a female patient, spironolactone away. If I had a male patient, maybe I would think about using eplerenone instead because of the gynecomastia. It's a little bit more specific to the receptors, so you don't have as much as that gynecomastia effect. That doesn't mean I wouldn't use spironolactone in males. It just means that I'd be a little bit more cautious. So my first go-to is going to be spironolactone, the vast majority of the patients. But if I had a patient who was really concerned or who ended up having breast tenderness on spironolactone, eplerenone would be another good option. Questions about spironolactone or the weird dosing of spironolactone for these patients? It's one of those times where you're at a retail pharmacy and you have a dose of spironolactone for 300 milligrams. That should be your red flag. Whoa. Let me call this physician or let me call this endocrinologist and make sure that this patient has an aldosterone issue. We don't typically use it for that high dosing in other situations. Okay? This should also reinforce your hypertension lecture, and that when you have patients who are really resistant to blood pressure medications and you tried with their blood pressure, a lot of times aldosterone is the issue. So if you have really resistant hypertension, you're not going to get it solved usually unless you have an aldosterone component to their drug regimen. So usually spironolactone, for those of you who've seen me in clinic, it's my go-to when I think their blood pressure is not being touched by a calcium channel blocker and ACE inhibitor. There might maybe an aldosterone component. Not that they have hyperaldosteronism, but just that there's probably an aldosterone component that's contributing to their blood pressure. All right? Okay. So for spironolactone, you may or may not have gotten to your max dose of spironolactone, but some other agents we can use. So the next class that we would prefer is ACE and ARBs. Why would we prefer ACE ARBs? How do ACE ARBs work? Somebody in Athens, how do ACE ARBs work? What system do they work on?
Renin-angiotensin system.
Very good. And what's part of that system?
Aldosterone.
Very good. Right, so ACE-ARB works in that RAS pathway, and related to the RAS pathway is aldosterone. So if you were going to pick another agent for these patients, you would pick ACE-ARB. What's our hesitation with ACE-ARB in a patient who's on a high dose of spironolactone?
Potassium.
What do you monitor for ACE-ARB? Potassium.
Renal function.
Renal function, right? So you check your serum creatinine and your potassium. So we have hyperpotassium, oh my gosh. We'll go with it because it's easy. We'll call it hyperpotassium right now. You have high potassium levels. For ACE-ARB and for spironolactone, you have potential for acute injury or situations where you can't use ACE, ARBs, and spironolactone in patients who have renal dysfunction. So we're worried about kidneys, we're worried about potassium, and they overlap. So you just have to be a little bit careful. But in lieu of spironolactone, you can use ACE, ARB. And then ultimately you have to get the patient's blood pressure under control, right? So ultimately, down the line, you could use a calcium channel blocker, or you could use a thiazide diuretic. Okay?
Dr. Misher,
Yeah, go for it.
for this condition, are you saying that you would try probably like spironolactone or eplerenone first and then try ACE or ARB? Or start with spironolactone and if it doesn't work, add on ACE or ARB?
Start with spironolactone, go to the max dose that the patient can tolerate, and then go to ACE ARB.
In addition?
You could do it in addition if the patient can tolerate, but chances are they probably won't.
Thanks.
Because you're monitoring the same parameters, like you're having potassium issues, and that's what's probably limiting your spironolactone is either A, your kidneys, or B, your potassium. So the chances of using spironolactone and ACE ARB in combination may not be possible. Although you may have a diagnosis of hypertension before you have a hyperaldosterone, so they might already sneak in an ACE and ARB and already be on an ACE and ARB, in which case I would just continue that and then add spironolactone once we had the diagnosis of hyperaldosteronism. Like I'm not going to go back and take it off, so then I'm going to start to maximize the spironolactone. Does that make sense, but also make it a little gray?
I get it. Thank you.
Okay, perfect. Perfect. And then our calcium channel blockers and our thiazide diuretics can have the opposite effect in aldosterone. They can kind of increase your aldosterone level. So you don't want to use them, but ultimately you have to get the patient's blood pressure under control, so they might be your only option. So that's why they're kind of after our ACE, our spironolactone, because they can have the opposite effect of what we want in terms of affecting that aldosterone level. Okay? So if we had really high, or if we have limitations in the disease. So if we can't use more spironolactone, we can't use an ACE and ARB because of the potassium or because of their kidney function, then you would have no choice but to use a calcium channel blocker because we need to get the patient's blood pressure under control. Is that clear? So really monitor potassium, really monitor serum creatinine. But you can go up to really high doses, up to 400 milligrams of spironolactone before you get there. Okay? Any questions about hyperaldosteronism?
Could you use spironolactone if the patient was pregnant?
Can you use spironolactone if the patient is pregnant? That's a good question I haven't thought about.
Please, don't
Let me look that up on Lexicon for me real quick.
I'm on Lexicon. What does it say? It like crosses the placenta, so I just
Hold that thought.
Just say,
We're going to move on, so hold the thought.
just tell her. Lexi said that it crosses the placenta. That's why I was wondering.
That's a good question that I'm asking. I don't really know.
should be avoided at first trimester.
Let me get back to you. Yep.
Yeah,
Just say it.
just say deal. Okay.
Okay, it's not a preferred option for sure. If they had high blood pressure, no, I wouldn't use it. Like if hypertension was my issue, I wouldn't use it in pregnancy. But if they had hyperaldosteronism and they were pregnant, that's a good question that I don't know that I have a good answer for. So for hypertension management, no. For hyperaldosteronism in a pregnant patient, I've never thought about that, so I'm not sure.
I think it just says that it should be avoided in the first trimester.
Yeah.
At the very bottom of that, it says when treatment for hypertension in pregnancy is needed, other agents are preferred.
There we go. Yeah, but that's in hypertension. So like we talked about your main problem is aldosterone or hyperaldosteronism. So what you would probably do at least in the first trimester and I'd have to verify this because this is not something I do on a daily basis. What you would probably do is switch to one of your agents that you typically use for pregnancy, and then you would maybe come back to it, but I'm not really sure. I'd have to like really look into it because it's not something I deal with on a daily basis. For hypertension, absolutely not. Like it's not my go-to agent for blood pressure and pregnancy. But for this particular disease state, that's a great question that I honestly don't have the answer to, and I have to look it up.
Under fetal arrest summary, it says it is indicated in the management of primary head loss.
There we go. Good researchers. All right, so we're going to move on because I will look it up. Good? All right, let's move on to Addison's. What is our concern with Addison's? What's going on in Addison's?
Not enough.
Low cortisol.
Low cortisol. Very good. So we talked about Cushing's having high cortisol, and Addison's we're going to talk about the opposite, having low cortisol. So, what do we use cortisol for? What do we change for? Stress. We're stressed out, we make that cortisol, and that gives us that fight or flight. I'm going to make it, I'm going to live, I'm going to get away from the leopard situation. Okay? Panther? Is panther better? Cheetah? Cheetah. We're going to go cheetah. Okay, so I need to run from the cheetah. I have cortisol that produces this fight or flight response, okay? Right now I'm teaching and I'm looking at all these little eyes looking at me. I have stress. My body has to deal with that, so I need cortisol in my body, okay? If you don't have cortisol, that is a life-threatening situation, okay? All right, so what I want to hone in on is that Addison's can be a life-threatening situation, and we need to make sure that our patients know that. Okay, so they need to understand their drug dosing. They need to understand that it's really important that they don't miss a dose. If you miss a dose, life-threatening situation, right? When to get to your point before, this would be more likely that I would ask you for a life-threatening situation in this case. Okay? Most of our patients, if you miss a dose, it's life-threatening because they have nothing to respond to stress. Okay? So if you don't have anything to respond to stress, you have to give it to yourself. So it is very, very, and I can't predict, right? I don't know if there's actually a code that's going to happen in the hallway right outside my door that's going to cause me to be stressful, right? I know that I'm coming in and lecturing to you guys, and that's going to be stressful. So maybe I can take a little extra something before I came in to handle my stress level. But what I don't know if there's going to be a code right outside my door, and that's going to add to stress. So for our patients with Addison's disease, it's really, really important that they have something on them. This is kind of like an EpiPen, is the way that I like to think of this. Is you never know when you're going to have an allergic reaction to that random peanut that ended up in your cookie. You don't know when you're going to have that random stress event that's going to cause you to have an Addisonian crisis. So you should have some fast-acting, like essentially EpiPen, we'll call it, hydrocortisone on you. Okay? So that's really important that the patient knows. Also, if that patient goes into a crisis, everybody else needs to know that they're in crisis, kind of like when you have a patient who has a low blood sugar, or you have a patient who has allergies or whatever it might be. So for one, they should educate the people around them, and for two, they should keep a medical bracelet or a wallet card that says, hey, I have Addison's disease, I just got stressed and my body couldn't handle it, so give me some hydrocortisone. Does that make sense? And then their drug treatments are obviously going to be giving them the glucocorticoids that they need to replace that cortisol. Questions about this piece? So when we think about our pharmacist role, this is where it's at. Drug education. Having that emergency on hand, hydrocortisone, EpiPen, making sure they have a bracelet, and making sure they don't miss their doses. This is when you have a patient who comes to the pharmacy and you see hydrocortisone or you see chronic steroids. We'll just add chronic steroids into this because we're about to have that conversation too with HPA access suppression. Right? These are the conversations we have. Okay? When you're in the ED, these are the conversations we have. the hydrocortisone dosing. For these patients, we typically use a dose of 15 to 25 milligrams. Okay? And we have a circadian rhythm. So our cortisol goes up and down throughout the day. All right? So we have higher cortisol in the morning because we have to wake up and we have to deal with the day. It's Monday. Right? So our body naturally produces more cortisol in the morning and less at night. What would happen if we had lots of cortisol at night? Be like me last night with these pregnancy hormones, just up like at 4 a.m., right? So don't want to have high doses at night because your patient's going to have insomnia. Okay? So more higher dosing in the morning, lower doses in the evening because you want to mimic that circadian rhythm. People are not making their cortisol the way that we naturally do. So I want you to know hydrocortisone dosing, 15 to 25 milligrams. I want you to know how to split that. So split 2/3 in the morning, 1/3 in the afternoon. Okay? In the afternoon, not super late. Like, don't give these patients hydrocortisone at 9 o'clock at night. That's me. I do it a little bit earlier in the day because you want them to be able to sleep. And steroids, they're going to tension up. Okay? So a reasonable hour. But again, it depends on their life situation. So if for some reason they need to be up, like if they have shift work or something like that, I'm not going to ask that when I'm not going to ask that on an exam. I'm not going to give them shift work disorder and make you adjust. Just know that we're going to, in an assessment situation, we're going to keep it basic, and we're going to say like they have a normal 24-hour circadian rhythm, and they function much like we do, where we're up relatively early in the morning, and well, maybe we don't all do that. Like, the vast majority of people maybe will say that they have a relatively normal, quote-unquote, life functioning, where they function during the day and they sleep better. Okay? So timing and dosing is really important for hypertension. I make lots of assumptions. When I have patients in the clinic, I'm like, wow, we're going to change this whole thing because now you tell me that actually your day starts at noon, so let's adjust. But I'm not going to do that for assessment purposes. That's okay. All right, you're going to adjust dosing based on symptoms, and then you're going to educate them a lot. Okay? So one situation that they will have to take an extra dose, or at least some piece of a dose, is before they exercise. Exercise is very stressful. If I had a patient that had to come and teach, then it'd be like maybe you want to have a little something on board because you know you're putting yourself in a stressful situation. Okay.
Do we have to know how much you will give for a PRN dose?
No, you absolutely don't have to know how much you would have to give for a PRN dose, but it would probably be dependent on the patient, and it would be lower, so maybe like a 5 milligram dose or something smaller. It would not be like a full dose, it would be something small, because that level of stress, and it depends on how long the stress is going to be there and things like that, but it'd be a relatively low, like maybe an extra 5 milligrams for them, that little period. Okay, we got the basics.
Dr. Misher, is that 15 to 25 milligrams the total daily dose that you would then divide into 2/3 and 1/3?
Very good, yes, that's total daily dose. So the 15 to 25 is their total daily dose that you would then divide 2/3, 1/3. So that's going to hit on their glucocorticoid. They might also have issues, other adrenal issues. So you might have to do a glucocortisone for mineralocorticoid, and you might have to do a DHEA for androgen. So they might have kind of multiple situations going on. But what I want to highlight is just the hydrocortisone. But realize that they might be on other therapies, depending on if they have mineralocorticoid and androgen abnormalities as well. All right, so in the Addisonian crisis, technically, really any of us can kind of have an Addisonian crisis because we all can be in a situation where we can suppress our HPA access. So anytime you have patients on steroids for a long period of time, you are putting them in a situation where you are essentially cutting off their normal adrenal response. So high steroids for a long period of time and you can have a person with a crisis. Again, you want to do something immediate, so you're going to do a parental agent in that case, usually hydrocortisone. Okay. Good. So HPA axis suppression can happen in any of us, anybody taking steroids for a long period of time. This is not the patient that comes in for a steroid burst because they have a cold, or in my clinic because they have a runny nose, and we give them a little prednisone burst to make them, all satisfied. That's not the patient who goes into Addisonian crisis. We typically think of patients over long periods of time. Although each patient is different, so it can have side effects. So that's what we're talking about here is HPA axis suppression. High doses, long period of time. So if we have a patient who's on steroids for a long period of time, we want to taper them off. You don't want to have an immediate stop. So you want to make sure you taper their steroid slowly, and typically we taper to side effects. So trying to see how is their disease state going, taper them down off their steroid. The other alternative way to do it is to, if you're going to have a patient on high doses of steroids for long periods of time, is to not give them steroids every day, but to use it every other day. If you had a condition, chronic steroids, you could potentially use it every other day, and that gives that HPA axis a little time for rebound in between, and so you don't really have as much HPA axis suppression as you would with daily dosing. And so two methods, taper and do every other day dosing. Where else do we have the impact as a pharmacist when it comes to steroids is that we see steroids very, very commonly in every clinical situation you can think of, right? We constantly see steroids. So knowing steroid counseling is very, very important. So if you were to pick a slide to study, I'd probably pick this one. And the reason I want you to study it is because you are going to see this in your clinical practice. I see this a lot in clinic. Okay? So we talk about carrying an emergency card, increasing your dose of stress, knowing the side effects. Insomnia is a huge side effect of steroids. Even your little bursts can cause insomnia. So even when you have that little steroid burst for that sniffy nose, you can have insomnia with that, so it's a good thing. Patients eat a lot on steroids. You have to monitor their blood sugars, their blood pressure. And in long periods of time, we have chronic wound healing issues. All right. Have you seen this in other classes, steroids? So this is not new. That's what I thought, but I wanted to bring it to attention just to make sure it's covered 100%. Okay. There's nothing special on this slide that you haven't already learned, I don't think. But I wanted to bring it here to you again. All right, so we're going to do case number 2. Again, I'm going to give you maybe like 2.5 minutes, because I want to make sure we get to a couple more things. In fact, let's just go through it together. Sorry to those students who really like to read. Read follow them. I'm going to read the case, and then we're going to talk about some highlights. I want to make sure that we have proper time to cover things that I want to cover. All right, so our chief complaint here is that the patient's losing weight. So we said with Cushing's, they gain weight. With Addison's, they lose weight. Eating salty foods. They're changing color. So they're gaining pigmentation, so higher pigmentation is another sign. They're tired, and they just want to sleep all the time. Okay? It's a 19-year-old patient, and they come to their outpatient. So this is not an emergency situation. They're coming to their outpatient, so I was in the emergency room after I had cortisone them, right? He states that he's not been working out like he used to because he has low energy, and he has less time in the sun because he just feels like he's getting a tan without even being in the sun. So really cool. This is like my favorite picture of Addison's disease is JFK. How he had that beautiful tan skin because he's Addison. Okay. It's like the picture that always flashes in my mind when I think of Addison's disease. He has a family history with mother type 1, father hypertension, brother no health conditions. He's unemployed, doesn't smoke, drink or do illicit drugs. He has diabetes himself. Yes, he's hypothyroid and type 1. Hypothyroid and type 1 also usually come in combination because it's typically a immune response. So have immune response to adrenal gland. You can also have immune response, obviously, to decrease in other organs. So hypothyroid and type 1 usually go hand in hand. So he treats it with his Novolog, and he's got a pump, he's got levothyroxine, and he uses Tylenol as he needs. Doesn't have allergies, has fatigue, depressed, which is also common. He has low blood pressure, so we talk about the opposite of Cushing's, where we have high blood pressure. This time he has low blood pressure. And you see his labs there, also indicative of absence. So our first question is, what are those signs and symptoms? We already talked through quite a bit of those. He's tired, he's lost weight, he has that hyperpigmentation. Okay. What is our goal of therapy is obviously A, to correct his cortisol levels, and B, to make sure we do really good education, and make sure he knows how to deal with a crisis. So we talked about dealing with a crisis and being able to have that emergency supply of hydrocortisone. All right. Non-drug education, kind of like similar to the same question, right? Stress management, making sure that he has that bracelet, medical bracelet. So what are we going to treat him with? Hydrocortisone. If we're going to put him on a 25 milligram dose, total daily dose, then how would we break that up? How much would we give him in the morning? What is 2/3 of 25? Sorry, I really put 1/3 milligram dose right there. I don't know what I wrote. Did I already have one? I don't know what I wrote. Anyway, so if we put him on a, let's think of a easier situation to put him on. If we had him on a 20 milligram dose, oh, sorry, that's what I did. If we had it on a 20 milligram dose, thank you. I can't do math in my head this morning. If we had him on a 20 milligram dose, it's a lot easier to think through. How would we divide that? What's 2/3 of 20 milligrams? Make it simple. What is his morning dose mean?
Could you do a 12.5 milligram?
You could do, if you had, no, sorry. 20 milligram dose, 20 divided by 3 is what? 6 point something-ish. Yeah. So if you double 6-ish, it gets to 12. So yes, it could be 12 and a half, but I would just round that to 15. What I did. And then I get 5 in the afternoon. So it's ish. So do some rounding. Essentially 2/3, 1/3. Ish.
5 is 1/4 of 20, not 1/3.
It will be clear.
Why can't you do 30?
2/3, 1/3-ish. I'll go back and check my math and make sure I did it right for assessment purposes. Right? 1/3.
She better give us like 15.
2/3, 1/3. We're treating with hydrocortisone. This patient also has a low blood pressure, so that's where we might come and think about hydrocortisone as well, depending if their blood pressure responds to the hydrocortisone. Okay. And then obviously we're going to monitor the signs and symptoms to make sure that sort of progresses and provide that education to make sure they know how to deal with a crisis. But they're also on steroids, so making sure they realize all of those side effects we talked about. They're going to feel like they want to eat a lot. They're going to have insomnia. All right, questions about that? I realize that was super quick. And I'll do some posting of cases to help you kind of think through it, because I know it's quick. Yeah. Questions real quick want to make sure we get those more things. All right, let's move forward to hirsutism. So when we talk about adrenal gland, we're talking about overproduction of androgens. And overproduction of androgens is going to lead to essentially hair growth and masculine features. If you're a female, you probably don't want those masculine features. So then we're going to do anti-androgen therapies. If we do anti-androgen therapies, for one, we can do spironolactone and finasteride, but we can also do estrogen therapy to reverse the androgen effects. Okay? We're going to keep that simple. Okay? So hirsutism, we know, is when our patients have overproduction of androgens. We want to reverse that effect, so we do the opposite. Okay? And that's all we're going to touch on that. The other thing that we're not, so we're going to switch to pituitary. It's a big class change right now, going from adrenal to pituitary. It's a different gland. The other thing we're not going to touch a lot on, because we're not going to see it very often, and again, you would look it up, is acromegaly. So acromegaly, if you want to think of like have an image, I'm a big image person. If you want to have an image in your head, there are a bunch of the TLC shows on TV that talk about gigantism. That's what these patients have. They have acromegaly. And so the way that you treat acromegaly is by taking out the pituitary situation that's causing it. So if there's a tumor or whatever it might be, it's really resecting that out. It's a little bit harder to catch because we typically don't think of it until the patient hits puberty. It's when it really becomes an issue. So at that point, you do some sort of modification at that point. And then what you really want to do is stop that growth hormone that's being released by the pituitary. So acromegaly, we're specifically worried about growth hormone, and we want to stop growth hormone. And we can do it in a few different ways. We can stop its release. So dopamine agonists are going to stop the release of the growth hormone. We can stop its production. So somatostatin stops the production. And then we can stop it from binding to its receptors. So receptor antibodies. Okay? All right, so two more things I want to cover. One is hyperprolactinemia. So again, this is overproduction of prolactin, obviously, hyperprolactin, so too much prolactin. And we have a couple treatments here. Obviously, we can do surgery, as we talked about before, we can do radiation, and then we have pharmacotherapy options. These are also things that you are not going to see very often. You're not going to see hyperprolactinemia. But I wanted to highlight just a couple treatments because you might see some of these for other things, especially bromocriptine. You don't see this much anymore, but you used to see it. And one thing you probably won't see very often, but should throw up some red flags, is, I can say it, pergolene. Sorry, pergolene. So if you see it, I want you to have some red flags. And the red flag that I want you to have is these adverse effects, because they're pretty significant. So CNS, GI, hypotension. So specifically for these treatments, I don't need you to know dosing. I need you to know that they treat hyperprolactinemia, and I need you to know that they have pretty significant adverse effects. CNS, GI for both of them, hypotension. So hypotension for pergolene. All right, so all of these treatments are targeted at reversing that high level of prolactin. That's what our third case is about, and I'm going to post answers to your third case because I really want to get into gender dysmorphia. Okay. Any questions about, I know I went through it quick, but but I'm going to post the case for you. I encourage you to read over the case, and I want you to know adverse effects of this drug.
I have a question about the HPA axis suppression. So under the pre-class lecture, you put that after hirsutism, but then under the in-class lecture, it was after something else. Which one does that go with?
HPA axis suppression? Sorry, I moved it. It was Addison. That's why I moved it.
So it doesn't go with hirsutism, right?
No.
Okay.
No, more so with Addison, where it's its own topic. So when I taught it last year, I did sort of all the adrenal issues, and then I took it apart and I put HPA axis suppression by itself because it's its own topic. But that's why I moved it, because I think it makes more sense with Addison. So Summer's question is, say your question again.
So it's used in Addisonian crisis, HPA axis suppression.
HPA axis suppression happens anytime, which is why I took it out and did its own thing last year. This is why. That was the debate where I put it. HPA axis suppression happens anytime that you have a patient on steroids for a long period of time. So it's kind of like its own adrenal situation that you induce, like we induce as healthcare providers because you give a patient steroids for long periods of time. But it has the same kind of effects that Addison's disease has. It's the same function in the body in that you're suppressing that adrenal response to stress. So it's most similar to Addison's, but it's its own condition because we create it artificially. Does that make sense? We give the patient steroids. So us giving the patient steroids for long periods of time at high doses causes essentially quote unquote Addison's type scenario. That's why it's moved in two different places. The pre versus in class. Does that make sense? Like us creating Addison's with quotation marks around. You guys can't put my air quotes on it. All right, any questions thus far? Because I want to get into at least a little bit of gender dysphoria.
Back to the hydrocortisone dosing, do you use that same 2/3, 1/3 rule for the cortisone acetate and the prednisone too?
Yes, ma'am. Yes. So depending on what agent you would choose, you would do either way because you're replacing that cortisol. So anytime you replace the cortisol, you want to mimic the natural circadian rhythm. So you do 2/3, 1/3. Ish.
Thank you.
Yeah. Not the same with your mineralocorticoids because your mineralocorticoids are different from your glucocorticoids. But anytime you replace your glucocorticoids, I think I added some extra syllables. Glucocorticoids, you want to do 2/3, 1/3. All right, purpose will pause to make sure that we really understand what we've covered thus far, and then we're going to talk about gender dysphoria. Okay? I think you'll feel more comfortable with the hyperprolactinemia after I post the case as well. So it's pretty basic, but a case to support y'all. Okay? All right, let's talk about gender dysmorphia. So what is our non-medical term that we typically use for gender dysmorphia?
Transgender.
Transgender. Very good. So we have lots of different ways that we refer to transgender patients. But when we think medically, if we're going to give a diagnosis, and this is really important, that we diagnose, the actual diagnosis is gender dysmorphia. Once you give a patient a diagnosis, it's really hard to ungive a diagnosis, and a diagnosis of gender dysmorphia comes with consequences when it comes to that patient's life, really, right? So when we have an actual diagnosis of gender dysmorphia that has social consequences, okay? So for one, I want you to all be aware of that, right? We make laws, we make situations dependent upon whether a patient has that specific diagnosis, okay? When we deal with patients who are transgender and or we have an actual diagnosis of gender dysmorphia, then we have to be very vigilant about what pronouns we choose to use for those patients, okay? So most of the time, we will ask them what pronoun you want to use. It is best practice to make sure you document that pronoun in the electronic medical record, that you address the patient appropriately. And the other piece is that somebody may not in clinic display on the outside the gender in which that they identify. So I may present as a patient to clinic dressed in what we would typically think of with quotation marks around a female dress, but I may identify as male or I may identify as female. When we think about pronouns, it's really important that we document the pronoun in the electronic medical record to know which pronoun, because the way that they present to clinic may or may not coincide with what we think of as that typical pronoun. Okay. I wanted to introduce a concept of cultural humility. So cultural humility is, as a healthcare professional, that I'm not sure if I'm going to do this justice, but as a healthcare professional, I am humbled essentially to my patient. And although I may or may not disagree with what they believe to be culturally true, I'm going to show honor and respect to their belief system. Okay? So cultural humility is a way of me acting as a healthcare professional in my professional role and coming to the patient and being understanding of where they are in terms of culture, in terms of their choice on how they choose to live their life and the decisions that they make and how that relates to the medical care. Okay? So cultural humility is the way I like to think of it, and this is not a very good, perfect definition, but the way that I like to think of it is that my personal beliefs are separate from my actions as a healthcare professional. And my role as a healthcare professional is to meet the patient where they are. Patients with gender dysmorphia, to back up, patients who are transgender may or may not choose to legally change their name. They may or may not choose to be called a different name than what their legal name is. Okay, so just like pronouns, there are ways in the EMR to document names and multiple names if need be. Depends on the EMR, EHR, but different EHRs have different ways of doing it. So whatever institution you're at, really understanding how to see those things and figure out what is their birth gender and what is their current gender, and then what is their previous name, what is their name now, are important things to think about when you have a patient with gender dysmorphia. Questions about this concept? All right, when we're thinking about gender dysmorphia, so typically, and we say typically because there's lots of gray area here, we think of not treating the patient until they actually have, with pharmacotherapy anyway, until they actually have the diagnosis of gender dysmorphia. Although this is a situation that waxes and wanes with the time and with the patient and how comfortable the patient is with having that as a medical diagnosis. But typically we try and wait until they have the actual diagnosis to start therapy, the gray area. So for feminizing hormones, feminizing, so if the patient is transitioning from male to female, we want to give them those female hormones. So we give them estrogen. You want to start with estrogen, and you want to add androgens later. Most of these patients have known or have prepared that they are going to start therapy for a long period of time. Most of the time they're super eager to get started on therapy, so they like just give me the whole thing. You don't want to do that. You want to start estrogens for a period of time and then add on your anti-androgen therapy later. Okay, so estrogen first, slow down, add the anti-androgen later. Okay, that's totally simplifying this, but we're going to call that feminist therapy. Masculinizing therapy, we're going to give them testosterone. Testosterone comes in a bunch of different forms. Have y'all had this in women's health prior? I have some head shakes yes and some head shakes no, so I want to make sure we cover it because it's also a place as a pharmacist I have a really big impact. It's testosterone therapy. So there's lots of different forms of testosterone. There's injectable testosterone, but then there's also patches and gels. Okay. Obviously, we're going to have the best effects probably with our injectable therapies, but depending on access, that may or may not be a possibility. So some patients do patches and gels, although you're not going to get the same response. The blood levels typically do. Most important counseling point for testosterone is something we already know. If you have a testosterone gel, I'm having like blank faces here in Savannah, so I'm going to assume that the answer is no, you guys haven't.
Clean your hands and avoid women touching it.
Women touching, avoid women touching. Yes, you're completely correct, right? Wash your hands and avoid touching women and avoid touching kiddos.
Oh my
God.
You're so close. So close.
Spreading that testosterone to women who don't want to be masculinized and to children who aren't ready to be masculinized yet. Okay? So we have testosterone therapy, very, very, very good. You hit it right on the nail on the head. Okay? Make sure you wash your hands. And make sure you put it in areas that when you go to give some love to little kiddos that, you know, little kids, I don't know about everybody else's kids, my kids are crazy. So like literally all over me. So you have to make sure you put it in places that little kids are not going to be all over. So you're putting it in places that are going to be covered, or you do it in a way that the kids are not going to be touching that testosterone gel or cream or whatever you might do. Does that make sense? Okay. So when a patient comes to your retail pharmacy and they pick up the testosterone, it's like a 2-second, hang on a second. Oh, you have that little kid with you? Let me talk about this. 2 seconds. Make sure you put it in the right place and make sure you wash your hands. When you're in the inpatient setting, you have your nurses and they're giving testosterone gel to a patient. Hey, make sure you use your gloves. Okay? Questions about gender dysphoria? Okay. All right. Questions about lecture today? All right, I think in 2.5 minutes on ELC, but it's probably the top part. Oh, is that, you guys already did it? Okay. Oh, you will, so there is, oh, you got the password, so you didn't do it already.
It's
So
got
that
the
is
shark
it.
on
Okay, let me see if I can fix it. Give me a second.
What's she doing?
I don't have good.
They gave you a 0? That was mean.
Oh, so now you care about her grades?
Now she cares about the grade.
It is 2:45.
I texted him. I could sense it.
Oh,
Okay, if you have issues with the quiz, then let me know, okay? I'm gonna stay here until the quiz is over. After you guys are done quizzing, you're more than free to go. I will post some answers to some cases to make you feel a little bit more comfortable. Please let me know if there's any questions about lecture, about anything that felt scary today. Deal?
Hold on. Me too.